All right, good morning, everyone. Welcome to our regional clinical rounds. Today, we have the honor of hearing from Professor Kenneth Chapman from the University of Toronto, the UHN. He's the director of the Asthma and Airway Center, and he's also been for a long time the director of the Alpha1 Antitrypsin Registry. If you're in the COPD world or the asthma world, you know his work. Clinical trials, guidelines, over 600 publications, over 22,000 citations. Tremendous success in the academic realm, very good clinician, and a very organized and clear approach to things, especially when it comes to airways disease and when it comes to alpha-1 antitrypsin deficiency in particular. The newest guidelines have just been published. And of course, Dr. Chapman is one of the authors of those guidelines. So he can provide a very unique perspective from a practical clinical perspective, as well as the basic science perspective. So he's going to speak to us today about alpha-1 antitrypsin deficiency. Everybody, please enjoy.
Well, thank you. I'm delighted to join you at regional rounds this morning. I love the camaraderie. I love the academic discussions. Most of all, I love the parking pretzel. That was delightful this morning. I think the rounds are timely, but that's just me. I've been immersed in this quirky alpha-1 antitrypsin world for a quarter century. But some things have happened. And if you've been ignoring alpha-1, haven't thought about it for a while, I think today's rounds might alert you to a couple of things you need to know and bring back to your practice. I'll try and go through this quickly so we can get to the Q&A part of things. Inevitably, my second slide, if it appears, will be that disclosure slide. So whether it's consultations, research, lectures, I've worked with some really dodgy people, so watch out for what I'm about to say to you. This is a disclaimer slide that's been given to me. I think the folks at Takeda, who make an alpha-1 augmentation product, want to be sure that you hear what I have to say, but they don't want to claim any responsibility for it. That's my read on this slide, so take it for what you will. Objectives. I hope you're going to be, at the end of this talk, much more familiar with alpha-1 antitrypsin deficiency and understand that we're missing it. It's out there. There's a lot more than we have recognized. And I hope I gave you some tips on how to avoid missing it, because it's going to be in your practice if you're practicing respiratory medicine. We'll talk about the clinical benefits, the actual benefit to patients of augmentation therapy. You may have been calling it replacement therapy, but remember, we're not replacing anything, we're augmenting and pumping it up. And the big story, the reason we're talking about this so much, is that Canadian Blood Services is now making this form of therapy widely available for Canadians who meet the medical criteria. So why are Canadian healthcare providers reviewing alpha-1 antitrypsin deficiency in 2025? And the answer is here. I'm sure you go home nightly and read what Kenneth has to say to you about healthcare materials and devices. In case you haven't come across Kenneth before, they're the folks who sit down after Health Canada has approved a drug or a product. They sit down and they look not only at the clinical trials, but they look at the context and say, you know what, this treatment not only works, but it's worthwhile and should be funded by the system. So if you're reading ahead and reading what's down there, you'll see that an alpha-1 antitrypsin product, the brand name is Zemera, was reviewed by Kenneth. And if you look up at the top left-hand corner, this was 2022. And based upon, I'm going to add, Canadian-led research, Kenneth came to a conclusion. They said, this treatment should be reimbursed, and that next couple of words, with conditions, means, well, you got to have the disease in order to get reimbursed. So those are the conditions. So here it is, in a little bit more detail. Kenneth said Canadian plasma product. This is, after all, a purification of plasma that we're talking about. The product should be reimbursed for maintenance treatment. This is the once per week intravenous treatment for adults with severe deficiency. And then it said, for example, and then you'll see genotypes. And you may remember vaguely from medical school, Z is the abnormal gene that was first described as being responsible for alpha-1 antitrypsin deficiency. People with two of those abnormal genes, PIZZ, those were people who would potentially benefit from augmentation therapy. PIZ null, that's what it sounds like. One very abnormal gene and one gene that isn't doing much of anything at all. Null, SZ, we could talk about that. That's a special circumstance. But in genetic terms, they said, people with those abnormal genotypes might well benefit from this augmentation therapy. That and having emphysema that a clinician can detect. So this might be a bit of a wake-up call. If you haven't been screening for alpha-1 antitrypsin deficiency in patients with persistent obstruction. So I'll ask the room, but I won't ask anybody to raise hands. At home, on Zoom, you don't have to raise your hand either. How often have you sent off a serum level for alpha-1 antitrypsin in a patient whose FEV1 was abnormal and could not be made normal? Whether that's an 80-year-old, 90-pack-year smoking emphysematous patient, or for that matter, a 55-year-old patient with dreadful asthma and, I hope you can see the air quotes, remodeling. All of those patients, both of those patients, need to have a serum level measured to rule out the possibility that their persistent obstruction is caused by alpha-1 antitrypsin deficiency. If you know of a patient in your practice with alpha-1 antitrypsin deficiency and obstruction, and you have not prescribed augmentation therapy because, in your judgment, it doesn't work, hang on a second. A whole lot of experts have weighed in. They say it works, and you don't get to withhold that potentially life-extending therapy from patients because you don't happen to like the treatment as described in clinical trials. And finally, if you've been watching patients in your practice with alpha-1 to see if they're declining rapidly, stop doing that, please. That's a disastrous approach. Whoops. So a bit of history, and you may have seen a slide like this or something like this in the textbooks. Alpha-1 antitrypsin deficiency, when it was first described by Laurel and Erickson in the early 1960s, was thought to have a prevalence of about 1 in 1,500. That may have been true in Scandinavia. In Canada, it's more like 1 in 4 or 5,000 individuals with the deficiency. It's a deficiency of a 52 kilodalton protein or glycoprotein. Most of that is produced by the liver, although alpha-1 antitrypsin can be produced by other cells. The natural history, we don't really understand it fully. We don't understand why some people with the deficiency will manifest with emphysema, some will manifest with cirrhosis, some seem to survive a long time without getting either. But clearly the tendency to get emphysema is quite strong. That's why we see it appearing early. That's why we often see it appearing with a minimum or even an absence of tobacco smoke exposure. What you're seeing there on the right is something you won't see much of anymore. This was in the early 1960s, cutting edge laboratory technology. Laurel and Erickson would put serum down on an electrophoresis plate. They would attach positive and negative electrodes, and they would let the proteins race across the plate. That bottom streak of blobs, that's normal serum. Up at the top, you can see that where there is supposed to be an alpha-1 band, there's just about nothing there. And this is an individual with alpha-1 antitrypsin deficiency. Now, some clinical biochemists might have simply said there's variability here. They were more diligent. They went back to see where the samples had come from. They often came from pulmonary wards, and they eventually realized that the samples came from people who had this early onset basilar type of emphysema. A little bit later, the liver consequences of deficiency were being described. I'm going to focus on lungs today. I'm sure you'll be glad of that. And here's an important picture. In fact, it's so important, I'm going to bring it back in a moment. But on the left, what you have is normal lung parenchyma, a nice dense sponge with lots of surface area for gas exchange. On the right, we see lung tissue that's been damaged, that's emphysematous. We see this loose mesh. On an X-ray, that parenchyma on the right will look very dense. It will look very lucent. It will look very black. That's also a picture to have as a clinician. And in a few slides, we'll talk about how we might quantify that. So what we'd like to do, of course, is detect that emphysema. We'd like to prevent that emphysema from worsening or repair it if we could. So here's the relationship between the risk of lung and, for that matter, liver disease and serum levels of alpha-1. By the way, I'm very happy with this graph. It's one of the few graphs that talks about serum alpha-1 antitrypsin concentrations in micromoles. That's what it says in the textbooks. And over here, serum alpha-1 antitrypsin concentrations in milligrams per deciliter, which is what Life Labs and all the other labs will report to us. Usually we read about this and then we get a report from the lab and we can't translate it. Just to continue for a moment, 57 milligrams per deciliter is considered to be a protective threshold at which you're not likely to get important lung disease. That becomes important in a few minutes when we get to Canadian Blood Services. This dashed line is roughly the lower limit of normal serum alpha-1 antitrypsin levels as seen by Life Labs or any other lab. So as you can see, 2M or normal genes will yield normal amounts of alpha-1, and this great big band will tell you that alpha-1 is an acute phase reactant. The level wanders all over the place, but typically it's well above 90 or 100 milligrams per deciliter. Carriers, one abnormal gene, one normal gene, they have very little risk of developing emphysema. They do have a variable serum level, and sometimes the serum level will be below normal. When you start screening for alpha-1, you will find a lot of carriers, and these are people with serum levels of 70 or 80 or 90 milligrams per deciliter. It comes out in the column of the report that's abnormal. You do have to drill down and get genotyping, but at the end of the day, it turns out not to be terribly important. SS we rarely see for obvious reasons. SZ we do pick up. That's an intermediate deficiency. We think some of those people have the potential to get into alpha-1 trouble. ZZ, that's what Lorella and Erickson first described. Null, those people are really in trouble, at least with respect to emphysema, although they're not producing any protein to pack the liver, so they really don't get in the way, much in the way of liver problems. Can we treat this? And of course, it may occur to you that if alpha-1 levels are low, one might boost those alpha levels or augment those alpha-1 levels. And it was way back in the 80s that Weavers and NIH investigators working with Cutter Labs found that they could purify plasma protein, purify alpha-1 antitrypsin, infuse it, and here's the magical number they came up with at an infusion dosage of 60 milligrams per kilogram of body weight once per week. And what you're seeing is a handful of severely deficient alpha patients, that's their serum level over here, infused over the course of half a year, that's weeks at the bottom, and we can see, days at the bottom, a sharp rise, of course, in serum levels after infusion, the gradual decrease in serum levels, and then the infusion is repeated. And after 4 or 5 infusions, they stay above this protective threshold that we talked about a moment ago. By the way, in that study, they also did bronchoalveolar lavage, and they could find this normal infused protein in the lung. So they felt that they were doing a good job. This is all biochemistry. They felt that they were doing a good job in bumping up serum levels. And on that basis, in Canada, in the United States, in Germany, in a great many countries, alpha-1 antitrypsin augmentation therapy was approved So you may not be aware of this. A great many pulmonary doctors, oddly enough, haven't been aware of this in Canada. But augmentation therapy has been prescribable in this country for almost 30 years. But soon after it was approved by Health Canada, Canadian Thoracic Society weighed in and said, you know, we're not so sure about this. I mean, if you want to tell the truth, the augmentation therapy had been taken to the blood specialists who said, yeah, it's a good blood product. Go with it. And the Canadian Thoracic Society said, whoa, we're in charge of lungs around here. And we're not sure, thank you, that lungs benefit from these infusions. We want to see lung endpoints reported. Seems reasonable. Does infusing people with alpha-1 antitrypsin that they don't normally have enough of, does that prevent the progression of emphysema? So the Canadian Thoracic Society said more research is needed, which convinced a great many pulmonary doctors that this was not prescribable. They could only get this stuff during a clinical research trial. But the trial that was needed was pretty clear. Everyone here can design it, find people with alpha-1, randomize them to get infusions or saline infusions, and then track spirometry. What could be simpler? Bit of a problem, though. Couple, actually. One, it takes a long time to develop emphysema that's measurable, especially by spirometry. As much as I'd like it, it's a pretty crude, noisy signal. So it's about a 5-year trial. Never mind, we can do this. Except if you do the power calculation, we need about 500 people in each treatment arm. That's 1,000 patients with alpha-1. The largest randomized controlled trial published in Alpha1 to date is the one we published in Lancet in 2015. It was 180 patients randomized. It took 24 sites collaborating internationally over 7 years to do that 2-year intervention trial. What you're looking at is an impossible trial that is never, ever going to be done. Bear that in mind as the Canadian Thoracic Society weighs in, as it will repeatedly in this area. So what's our solution? Our solution is to find something sensitive. So I am not going to tell you that lung density should be part of your practice in managing COPD of all kinds. But remember, in alpha-1 antitrypsin deficiency, what we're looking at is a diffuse emphysema. It is as close to a homogeneous lung injury as one can get. And that's why lung density becomes a great endpoint. It's something that is actually more sensitive and more prognostically valuable than FEV1. Let me remind you, and I'm sorry, I should be moving the slides forward so you're all entertained with pictures, but I know that this room has occasionally looked at the GOLD strategy. You'll know that from its pharmacotherapy 4-quadrant algorithm in 2011 to the present, it has gradually abandoned FEV1 except for diagnosis. Once you know there's obstruction and you know the obstruction persists, you're dealing with COPD. After that, you run the pharmacotherapy based on symptom burden and exacerbation tendency. Why did they get rid of FEV1? Because it's a bullshit 200-year-old maneuver. I can say that amongst my colleagues in pulmonary medicine. But remember, only once a year do you ever make up and use the spirometric maneuver. Unless, of course, you're a patient with lung disease and you go to the lab, you do it. Blowing out candles on a birthday cake. It's not particularly functional. It's not particularly useful to you. But over a couple of 100 years, we figured out that it has some vague meaning that helps us to understand that obstructive lung disease is present. So let's set aside spirometry and let's actually look at lungs and how hyperlucent they get when they develop emphysema. So there's the picture. I told you it would come back. Can we quantify this? And in the interest of time, I have not burdened you with the technology. We can talk about it later if you want, but you can look up this paper. It appeared in Lancet, and it showed for the first time that in a randomized controlled trial, augmentation therapy protected lung structure or parenchyma as measured by lung density. And here's the picture. This is a 24-month, 2-year randomized double-blind control trial, and there's a 2-year open label extension. So in the first part, the line in black describes the decrease in lung density of alpha-1 patients who are getting saline infusions once per week and their lung density is dropping. The blue line are the lucky people who get alpha-1 antitrypsin infusions once per week, and their rate of lung density loss is less. This difference is statistically significant. And then when everybody gets augmentation therapy, the late starters now lose lung function, lose lung density at the same rate as the people who started early. But you notice that these folks who get a late start do not catch up. They do not recover their lung density. So if you wait, people will be losing valuable lung parenchyma. What we described as the first positive trial, but there were lots of indications that that was going to happen. There was an early Danish-Dutch trial. There was a later exactly trial, which was part of the planning stage for subsequent trials. And there was the rapid trial I've just shown to you. If you look at the decline in lung density, it looks pretty similar in untreated patients across the board. And if you look at treated patients, the decline in lung density also looks pretty similar. So these are robust findings. It's not a quirk, it's not a fluke. It's what you might expect biochemically, it's what you might expect clinically, and it's what we've seen before, albeit not in a statistically significant way. So what about FEV1? You're saying, no, I know, blowing out candles on a birthday cake, but I've grown up with FEV1. I just love FEV1. I want FEV1 to be preserved as well. So I told you that the rapid trial was a 4-year trial in total with the open label extension. If you look at, on the y-axis, changes in lung density, if you look at the x-axis, FEV1 as a percentage of predicted, the same thing that happens to lung density happens to FEV1. In other words, if you preserve your lung density, you will preserve your FEV1. And the contrary is also true. The same is true of vital capacity, by the way. So eventually, if you keep blowing out candles on a birthday cake and measure what happens, that will track with the much earlier signal you get from lung density estimates. In 2012, there was a Canadian Thoracic Society statement about Alpha1. If you've read it and understand it, it's still pretty much true. But I will tell you, and let me summarize, in terms of augmentation therapy, there was this support. It said if you have impaired FEV1, 25 to 80% predicted, in the context of Alpha1 antitrypsin deficiency, one should consider this augmentation therapy because of benefits in lung density and mortality that's based on natural history studies. There is a current statement. It appears online in PDF format in CHEST. It will appear in our Canadian journal. This was a collaborative effort following all guideline principles. Half the paper is taken up with those guideline strategies, but there's very little that's changed. The Alpha1 antitrypsin guideline deals with targeted testing, screening, if you will, most of us would say, and augmentation therapy. The augmentation therapy recommendation really hasn't changed. It says if you have emphysema and Alpha1, you should give some thought to giving augmentation therapy, and that's stayed. The changes are here. Screen patients with persistent obstruction. There was some waffling based on age and underlying diagnosis. Now it's a little clearer. Don't care what you call it, COPD, asthma, what have you. If there's obstruction, for God's sakes, screen. Number 2, the first statement said, don't bother screening in unexplained bronchiectasis. Now they say, okay, screen in unexplained bronchiectasis. And then finally, and don't be too confused by this, there's a recommendation to use standard genetic nomenclature, which is going to confuse the hell out of all of us, and also to request gene sequencing, which your local lab is not going to do for you until they know there's a need to do it. They are going to use SNPs or PCR based on 14 commonly abnormal Alpha1 genotypes to do their testing. It's much more efficient that way. If they can't explain an abnormal serum level, they will decide to go into gene sequencing. So let's go back to lung density. We're preserving lung density. We're preserving, we believe, lung parenchyma. What does it actually mean? Like, here I am exhorting, I'm emoting as best as I can with a cold at 9:30 in the morning, having driven around Hamilton for half an hour looking for parking. But I'm still emoting and trying to get you to find Alpha-1 and maybe even treat it. Why? Well, it's not that I love lung density per se, but some interesting things unfolded from the rapid trial. It's very informative. What you were looking at is a graph of lung density on the y-axis and a projected time frame on the x-axis, 30 years. Most of the patients entered the rapid trial with a lung density that was somewhere in the high 40s, high 40 grams per liter. Don't worry, I don't carry that number in my head, except that I've used this slide a few times. It's not something we're accustomed to thinking about, but that's where the patient started. Now, it turns out that if they started there and they were randomized to placebo, they would lose their lung density at a rate of about 2.2 grams per liter per year. There's this scary line, this dashed line that's labeled terminal value. Why? Because in the course of the rapid trial, 6 or 7 patients died or were transplanted. And it turns out that they died or got a transplant at about 20 grams per liter of lung tissue. So it seems a fair extrapolation to say if you start there and you lose at this rate somewhere around there, a little over 10 years, you're going to be dead or need a transplant. The people who got augmentation therapy had a lower rate of lung density decline, and that difference is about 6 years of life gain. By the way, these are all late diagnoses because we make the diagnosis of Alpha-1 late. And presumably, if you started up here, the difference would be even greater. So if you're one of those folks who said, I got an Alpha-1 in my practice, keeping an eye on it, you know, if there's going to be a decline, I'm all over it. I'm going to give this very intrusive treatment, this maybe expensive treatment, to rapid decliners only. So this next medical intelligence comes to you from a lovely young woman who I will tell you at the time was an undergraduate science student at the University of Toronto. She was immersed in our Alpha-1 registry data, and I was talking to her about this phenomenon, and she said, let me look at this. She took out the data on FEV1, the thing we use clinically, from a patient who'd been in the registry at that point for about 10 years, and she said, okay, these are the FEV1 measurements we have on file. This is the rate of FEV1 decline. I'm going to put myself in the shoes of the busy lung doctor in his practice. And if every 2 years you looked at the FEV1s you had on record, you would calculate this rate of FEV1 decline. Ooh, that looks like a bad year. Maybe you should start augmentation therapy. Oh, never mind. We're making FEV1. No, we're losing it. We're making it. We're losing it. It's a noisy signal. And she said, what about 3-year intervals? And that's the gray line. And it's not quite so noisy, but it's still a bit confusing. And it turns out, and we're not the only people to point this out, it takes you about 4 or 5 years to calculate a reliable rate of FEV1 decline. Now think about what this means. If you wait 4 or 5 years to find your rapid decliner, you will be inevitably in a position of saying, you have lost 400, no, maybe make it 500 cc's of FEV1 that you will never recover, because I've been watching to see if you're a rapid decliner. Dear God, if they have obstruction when you meet them, they have declined rapidly. That's how we calculate it. We have population predictors. You're lower than the population. You have declined more rapidly than the average population. Why would I ever wait to start this therapy that's going to preserve your lung density and extend your life? A little nuance here, and I won't blame anybody for getting this one wrong. I'll prescribe. I'm going to prescribe what we were prescribed or tested 60 milligrams of Alpha-1 antitrypsin product per kilogram per week. So let me take you back to medical school in a moment for dose calculations. There is, believe it or not, a dose response, or at least we have the hints of a dose response. This is also from the rapid trial. And you would say, wait a minute, you used either nothing or one dose of alpha-1. How do you do a dose response calculation? Well, no surprise here. You remember that volume of distribution concept from pharmacology, skinny people fat? Anyway, it turns out that when you infuse 60 milligrams per kilogram, you get slightly different serum levels. And if you plot the serum levels that you get, the blue dashed lines are the treated individuals, the dark dashed lines are the placebo-treated individuals. There is a relationship between how high you can drive the serum level and the protection you get in terms of preserved lung density. So the more you raise the serum level, the better the protection. It's kind of intuitive and yet hasn't fully been studied. There are some trials underway. What we do in clinical practice is this. Remember the standard 70 kilogram man? 60 milligrams per kilogram every week gives you an infusion of 4,200 milligrams. If you prescribe that, I tell you what will happen. Patients prescribed 4,200 milligrams of augmentation therapy will go to the Innomar clinic. The nurse will carefully draw 4 full vials, 1,000 milligrams each, 1/5 of a vial of the next vial, the remaining vial. The other 800 milligrams of precious plasma purified product is going to be poured down the sink and not given to the patient. So strange as it may seem, please round up to the nearest 1,000 milligram, never round down. And you will find that just about everybody gets 4,000, 5,000, and occasionally 6,000 milligrams of infused product once per week, round up. And just in case you do have some patients on treatment, it's surprising how difficult it's been to get this word out. In Ontario, patients have been able to get infusions through private insurance only, and that has meant infusions with a product called Prolastin C distributed by Grifols. That's going to disappear because the insurance company is not going to continue to provide that. Now that Canadian Blood Services makes infusions available for everybody through the blood distribution system. So it's not a change in product that Sun Life or Manulife is going to adapt to. It is a whole different distribution system, and the private insurance company is going to say, not our problem anymore. You're going to have to, wait for this, fill out some forms. You're going to have to get your patients approved for Canadian Blood Services treatment. It looks something like this. How do you prescribe? You find this form on the Canadian Blood Services website. It's not quite as difficult as it seems. Give us a call. We'll try and figure it out with you. Obviously, you enter patient information. The quirky part is indicating where the patient will pick up blood, which is going to be at the nearest large hospital with a blood bank. And you identify yourself, what respiratory clinic. So wherever you're based. On the back of the form, or on the second page of the form, they ask for some more specific information. So they ask for not genotype, unfortunately, they ask for the serum level. They ask for the FEV1. They ask to be reassured that the patient is not a smoker, hasn't had a transplant, and the patient is then eligible. Here is the update. So again, don't prescribe anything less than the full 1,000 milligrams. And there are lots of details about the vial size, quantity. Basically, patients are going to be asked to go to that blood bank in Hamilton and St. Catharines, wherever it may be, pick up initially 1 month supply of augmentation therapy in vials to be refrigerated. Later, it's going to be a 3-month supply. They might want to buy a small fridge for that. And they will take their 4 or 5 vials to the local Innomar clinic by appointment and have that infused once per week. And there are some phone numbers. We can come back to that if you want to copy it down. But in Ontario, you can fax your forms to these numbers. A little while ago, a very important group to know of was Alpha1 Canada. Don't bother copying this down. You won't find the website there much longer if it's still there at all. I mention it because it was a patient group, and I've talked a lot about doctors and research and publications in Lancet. But the real progress in Alpha-1 has been at the hands of patients. They were able to announce last February that alphas have access through Canadian Blood Services to life-extending treatment. And the shout out should go to this lovely and highly efficient lady, Angela Diana, who, as you can see here, was named last year as one of the top 25 women of influence. And that's because she did what I thought was quite impossible. She said, you know, this is a blood product. Why doesn't Canadian Blood Services distribute it? And she tilted at that windmill for 8 years. Imagine the bureaucracy. Imagine the meetings with assistant deputy ministers of health. Imagine flying across the country repeatedly and banging your head against that wall. And she did it. The reason we have augmentation therapy medically available in this country is because of this woman, citing some of our Canadian data and Canadian research, admittedly, but up till then, nobody had been paying any attention. What's next? And I'm going to leave you with a couple of thoughts. I've never seen a more exciting era in the field of Alpha-1 antitrypsin research. So one of the things that's in the near horizon is this recombinant Alpha-1 made by Inhibrx, a company in California. They have been picked up by one of the larger pharma companies. And what they've done is attach their recombinant Alpha-1 protein to an IgG4 molecule. And their expectation is that they will infuse once per month, not once per week, and that they will achieve not just improved, but actually normal Alpha-1 levels. And that doesn't mean it's going to work. These are early days. It's not approved. It won't be approved for several years, but that's something to look forward to. And that makes therapy much more achievable and patient-friendly. But also on the drawing boards, and it's really exciting, companion molecules. We have neutrophil elastase pills. That's not quite a companion molecule. We have the Vertex folks working on companion molecules, perhaps hoping to revolutionize in Alpha-1 what they did for cystic fibrosis. mRNA injections. If you've been scanning the news pages, releases to stockholders, you will know that we in Toronto have just converted, in effect, 2 severely deficient Alpha-1 patients to carriers with subcutaneous injections of mRNA modified therapy that is giving mRNA the instructions to produce normal Alpha-1 instead of the somewhat abnormal Alpha-1 you've been making. DNA correction is out there. It's been scary. Messing with Mother Nature to that extent is going to stay scary for a while, but there are companies that are doing it already. And if you're a hepatologist who snuck into the room, it is possible to inhibit RNA rather than giving it modified instructions. And if you do, it will stop producing Alpha-1 and stop packing the liver in the endoplasmic reticulum to produce cirrhosis. So quick summary, augmentation therapy. It preserves lung density if patients have emphysema due to their severe deficiency of Alpha-1. You can now treat, after some form filling, with augmentation therapy patients who have an FEV1 below 80% of predicted and serum levels that are below 57 milligrams per deciliter. I was about to say something rude, if you wait before starting augmentation therapy, it will mean patients will lose irrecoverable lung parenchyma. Don't waste valuable augmentation therapy. If you are using it, round up, make sure patients getting the fully available dosage. 60 milligrams per kilogram is almost certainly an underdose, although it doesn't work. So don't let anybody at the NMR clinic pour this valuable product down the sink. And with that, I hope there's been a little bit for just about everybody. I'm going to stop. Oh, yes, you get to scan that and evaluate rounds. So I'll let you do that.
Fantastic. I like the practical aspect of where people should pick up their drugs. The NMR clinic is across the street from the general. So if you're filling out the form and you put our hospital, it's, you know, the patient's having to go to 2 places. So that's very, very practical. So I'm very pleased that you left some time for questions. What I may do is just take advantage of where I'm standing and ask the first question. What do you advise people to do post-lung transplant? Should they continue their augmentation therapy?
One of the things we discovered in the shift from private insurance to Canadian Blood Services is that in the province of British Columbia, that's had the most wide open formulary access to Alpha-1 treatment from the get-go, is that there were a great many carriers getting treatment, which we do not believe is scientifically supported, and that's coming to an end. And there were a great many post-lung transplant patients who were getting infusions. That's the exception. And if you look across lung transplant programs around the world, they generally do not give augmentation therapy post-transplant. Now, the rationale is a couple of things. One is if you're a very rigid academic, you would say there are no studies to show that it's a benefit. But mostly it seems to be a back of the envelope calculation. Well, your transplant might last 6 or 10 years. That's not long enough to develop alpha-1 emphysema. So no, we're not going to give you augmentation therapy. There is a case to be made for augmentation therapy being a potential benefit. Alpha-1 antitrypsin is a very powerful protein. It is anti-inflammatory. I could hypothesize that you will see less bronchiolitis obliterans and rejection if patients with deficiency are given augmentation therapy. But remember, that's a hypothesis. So the quick practical answer to your question is no infusions after transplant, but it's an academic round, so I had to give you an academic answer.
Joshua.
So there was a webinar last night from the CTS, the new guidelines that's doing it. One thing that struck me there that I hadn't really thought about before is the way we talk about the alpha-1 types. We talk about them as genotypes, but the Z and S, it's really more about the protein that's one. But once we move to genotypes, we may discover that some of these people that we thought the levels were okay, there may be other deficiencies that are not as active. And that just got me thinking. I was wondering if you could speak to that and sort of if you're starting to see this in the population.
The general approach to finding alpha-1 is to do a serum level. And I didn't say this in the talk, so it gives me a chance to say now, this is cheap. This is widely available. It's a $4 or $5 test in the lab. Do it. And if it happens to be a duplicate test, it's not going to harm anyone. And then if it's low, even a little bit low, you send off for genetic testing and the lab comes up with an answer. Now, if the answer is, oh yes, there's an abnormal allele that we recognize, S, Z, whatever, they pat themselves on the back and they have an explanation. They'll report that to you. But it could turn out that using their 14 standard SNPs, they don't come up with an answer, in which case they will then go on to gene sequencing, and that's where they find the exquisitely rare genotypes that don't even have a name yet. Let's come back to a slightly different problem. You're looking at a patient. The patient is 35 years old, has smoked 10-pack years, has panlobular basilar emphysema, and you're going, that's got to be alpha-1. And you do a serum level, and it's in the normal range. What the hell? So you send this off to the genetics lab and say, look, I know the serum level isn't low, but I really want to make a case for this. They will go looking for dysfunctional alpha-1 proteins that produce a measurable serum level but don't work to protect the lung. Now, they probably don't have to get all fancy and do gene sequencing. There are commonly uncommon ones. F, as in Foxtrot, I, as in India, which produce dysfunctional protein that adds to the serum tally, which is why when somebody's got a serum alpha-1 antitrypsin level of 80 milligrams per deciliter, you look and say, I think it's a carrier. You still have to do the genetic testing because it could be a ZF, which is the equivalent of a ZZ and warrants augmentation therapy. Most of those common dysfunctional proteins are already known. They're in the 14 SNPs that the labs will routinely use. But if you think the lab may have missed something and you think you need something further, you can speak to the lab and they will go further with gene sequencing for you.
Sophie.
Thank you for that talk. I have a question. So I have a few young adult patients with alpha-1. My approach to this point has been yearly PFTs, and if everything's fine, that's sort of it. But should I be doing imaging then? Like when you're talking about lung density, how can you really screen for?
When you say a few, I don't know what your practice is like, but I want to make sure that these are severely deficient alpha-1s So people with serum levels of 20 or 30 milligrams per deciliter, ZZs in other words. And yeah, so those people may or may not develop emphysema. And if they're completely free of symptoms and have normal PFTs now, I would probably screen them every year or two, period. And remember that this does not affect only lungs. They may be busy packing their livers with malformed alpha-1. So I would have them see a hepatologist do a FibroScan or do a FibroScan, and again, let the hepatologist decide, but maybe every year or two as well, that should be tracked. But there are people who have serum levels of 70 or 80 or 90. They're MZs, and if they're MZs, I pat them on the head and say, go away, don't bother me. There will be a story of single gene variants. It probably is seen, it is seen 4 times more commonly in asthma clinics. I think in particular the S variant probably has a role in some phenotypes of asthma. That will be a story written after I've retired. We do know that carriers do crop up in COPD clinics, and their manifestations of COPD are a little bit different. The COPD gene spirometric people got their databases together and said, you know, those folks who are carriers, as compared to non-carriers for alpha-1, have more rapid rates of FEV1 decline, tend to have a more basilar distribution of their emphysema, but the impact is small. Until we have something like inexpensive Chapman molecules, neutrophil elastase inhibitors, or affordable mRNA injections, that probably won't be important, but down the road, we may actually consider treating some of those carriers who have COPD, but for now, we don't follow them. It's 2% of the general population.
Dr. Ragavan.
That talk, for bronchiectasis. So when you're primary sort of clinical bronchiectasis, you go searching for emphysema, and if it's there, you can get replaced augmentation and try it. I have one who's predominantly bronchiectasis from her hepatologist. And I was weighing, do we start augmentation, do we not? And not much.
The quick answer is there's no study of augmentation therapy in bronchiectasis, which is, of course, where academics move into the void and hypothesize and pontificate a whole lot. So you might say, well, maybe it would help, but I could equally say, well, maybe it will hurt. You might ask yourself, well, why do we have alpha-1 antitrypsin deficiency? It's persisted in humankind's genetics for a long, long time. Why do people in the Middle Ages, in dark, cold winters in Scandinavia, benefit from carrying alpha-1? And the answer is maybe a bit like thalassemia traits in Africa, that you are a little less likely to die from malaria if you have thalassemia trait, although putting 2 abnormal thalassemia genes together is bad news. You have sickle cell disease. So maybe if you're in the 1100s in Scandinavia and you have a little less alpha-1 antitrypsin floating around, your neutrophil elastase is not so blunted, and you fight off the pneumonia that's going to kill you at age 38. Fast forward to the present. So if you have bronchiectasis and you're bacterially colonized and challenged, does it help to add more alpha-1 antitrypsin to neutrophil, to neutralize neutrophil elastase? And the answer is, well, maybe not. Maybe that's actually a negative thing. So to come to your very practical thought, do I look for emphysema? Yes. If I'm starting to see emphysema, that I know I can influence, so I will give augmentation therapy. If it is so-called pure bronchiectasis, especially clinically with lots of infections, I will hold off and explain to the patient why I'm holding on.
Something that comes up sometimes is alpha-1 antitrypsin being an acute phase reactant, and picked up a few where their initial test was done in the setting of an infection, and you test them and their level was normal or even high, and then they come back months later when they're feeling well, and now their level is clearly low. Did that make it into the guidelines at all as a practical thing, the retesting or testing them when they're well?
I don't think that specific nuance made it into the guidelines. There have been recommendations to add a CRP to your serum alpha-1 antitrypsin level to catch this possibility. I have to admit, I don't do it. The highest I've ever seen a ZZ patient mount an alpha-1 level was 77 milligrams per deciliter, which would still be abnormal and would have resulted in genetic testing anyway. So I'm a bit slack about that. You're quite right. You caught me.
That's true. Yes, for weekly infusions with the usual vial amounts, would patients often require central access to the plumbing or PICC line or something like that?
Most of my patients just get their infusions through a butterfly once a week. But as we all know, there are some patients with horrible venous access, and those patients will get a PICC line or a central line. There may be some reasons to seek out a PICC line or a central line for some patients because the newer formulations of augmentation therapy, and that includes the currently available Glacia, are formulations that don't require elaborate reconstitution. In other words, a patient can be trained to self-infuse, home infuse. I've got patients who are married to retired nurses, so it makes life a little simpler.
That was excellent. I appreciate you giving us time for questions, and Dr. Chapman might be available at the front for a few more minutes at the end for additional